Ah, perfect. There is the magic robot voice. Hello, everyone. Thank you all so much for tuning in today to our third session of the day. Today's topic is all about xylazine. So I'm going to introduce our speaker, Dr. Sasha Kaiser. So she is the Associate Medical Director of the Washington Poison Center. She completed residency training in emergency medicine at Denver Health and Hospital Authority and a fellowship in medical toxicology at the Rocky Mountain Poison and Drug. Oh, I'm getting a notification that not everyone has fully gotten into the session yet. So I will do that introduction again in just like a minute. Apologies for that, Dr. Kaiser. You get to hear me repeat myself. All right. So I see about 57 attendees. So, okay, I'm getting the thumbs up to do it again. So folks who just joined, thank you for joining. Folks who joined a little bit ago, you get to hear me do this again. So today we are on our third session of the overdose series, overdose awareness series. This session is all about xylazine. So I'm super excited to introduce our speaker today, Dr. Sasha Kaiser. So Dr. Kaiser is the Associate Medical Director of the Washington Poison Center. She completed her residency training in emergency medicine at Denver Health and Hospital Authority and a fellowship in medical toxicology at the Rocky Mountain Poison and Drug Safety Center. Perfect. Dr. Kaiser, thank you for being here. Let's go ahead and get your slide shared now. As you're doing that, I'll walk through just a little bit of housekeeping. So folks, please ask any and all questions as you have them in the Q&A box. Everyone should have access to the Q&A box. We're going to monitor the chat box as well, but we're really hoping to use that more for comment, shared experiences, shared resources, as well as any technical questions you have. By the end or at the end of the session, we'll go ahead and share our survey. We're asking folks to complete a little survey at the end. You'll need to complete that survey if you would like to receive a certificate of attendance. All right, without further ado, I'm going to pass it on to Dr. Kaiser. Y'all can hear her instead of me. Take it away.
Well, good afternoon, and thank you for joining me today as we delve into the impact of xylazine on our communities. The National Survey on Drug Use and Health estimated about 59.3 million people used illicit drugs at least once in the United States during 2020. While use of any substance carries with it inherent risk, the presence of adulterants and street drugs adds yet another layer of complexity to drug use. These additional components or ingredients, such as xylazine, are typically added in non-commercial laboratories and are completely unregulated. Morbidity risk is increased for products purchased on the illegal, unregulated market as there's no quality control. As a result, drugs can contain unexpected substances of unknown quantities and have poorly known potency and toxicity. Xylazine, a veterinary sedative, has emerged as a significant concern. Today, we'll explore the multifaceted public health challenges posed by xylazine, including its role in drug-associated wounds, complexities of its detection, and broader implications for individuals and healthcare systems. By understanding these impacts, we can better strategize on how to address and mitigate the potential harms caused by this substance. I have no conflicts of interest to disclose. Throughout our discussion today, I'll be introducing insights from interviews featured in the paper by Friedman. These interviews, spanning from 2009, a time of early xylazine exposure emerging in the United States, to more recent accounts from 2020 to 2021, will provide valuable perspectives on firsthand experiences. By integrating these exposures, we aim to gain a deeper understanding of how xylazine has affected individuals and communities over time. To understand the historical context of xylazine, we need to look back to the 1960s when it was first synthesized by Bayer as compound 1470. Initially, Bayer 1470, an alpha-2 adrenergic agonist, structurally similar to clonidine, was investigated as a potential antihypertensive agent for humans. However, during clinical trials, it became evident that the compound induced excessive sedation, which was deemed an unacceptable side effect for managing high blood pressure in patients. Consequently, its development for human use was abandoned. Despite its unsuitability as an antihypertensive for humans, further extensive testing in animals revealed that Bayer 1470 had a potent sedative effects across multiple species. Importantly, the sedative action was achieved with minimal respiratory depression and appropriate use, a significant advantage over other sedatives which often compromise breathing. This discovery led to the compound being repurposed and marketed as Xylazine, an effective veterinary tranquilizer. Today, Xylazine is an FDA approved for use in animals, serving as a common sedative with analgesic or pain-relieving properties and muscle relaxant properties. Despite its powerful effects and wide veterinary use, Xylazine is not federally recognized as a controlled substance. This lack of regulation contributes to its accessibility and unfortunately to its misuse. It's important to note some of the common street names associated with it, such as trank dope, sleep cut, and zombie. These names reflect its recreational use, often extend the euphoric effects of shorter acting drugs like fentanyl. Xylazine has been a significant issue in Puerto Rico for over 20 years. It subsequently spread to areas such as the East Coast, Chicago, and Texas into the 2000s. Despite its widespread presence, Xylazine cases are frequently undercounted. This underreporting is due to it not being a nationally controlled substance, leading to inconsistent inclusion in crime lab data. Postmortem toxicology testing and drug seizure data by the USDA have really highlighted its presence. However, Xylazine's role varies. It can be an adulterant mixed in with other drugs, or in some cases used as a primary agent. The reasons for adulterants in illicit drugs are often varied. Additional substances can be added to add bulk, to dilute, to complement, or enhance the effect of the drugs. Others are present unintentionally, being additional elements as a result of manufacturing, production, or storage techniques. To understand why Xylazine has been used, one of the things that can be really helpful is to look at this from the opioid epidemic standpoint. The opioid crisis has evolved really significantly since 1999, with greater than 500,000 people dying from overdoses involving both prescription and illicit opioids. This tragic rise in opioid overdose deaths can be outlined in really three distinct waves. So a lot of this started in the early 1990s. At that time, the medical community really didn't realize the addictive potentials of opioids, and they increased their prescribing of opioids for acute and chronic problems. This led to a surge in overdose deaths involving prescription opioids, including natural and semi-synthetic. So in the mid-2000s, we started to recognize our mistake and really backpedaled, and there was a lot of increased legislation that was limiting opioid prescriptions. So all of a sudden, people who had been on opioids for a long time that had been prescribed by their doctor no longer had access to them. And so they had to turn towards things that they'd never had exposure to before. One of those things was heroin. And what you saw during 2010 was that there was a lot of people who had never used any IV drugs in the past, all of a sudden were using heroin because they had no longer access to the opioids that they had had some dependence built on. Then in 2013, there was a significant increase in overdose deaths involving synthetic opioids, particularly illicitly manufactured fentanyl. Initially, the fentanyl was mixed in with heroin as it would be a cheaper thing to use as opposed to the heroin. But one of the problems with this is that heroin is really short on, short off. And so what you will see is that patients will have this initial intoxication, but when you talk with them about their use pattern, a lot of people will describe I use it all day, every day. And what this really is because of this fast on, fast off. And so to have a semblance that's a little bit closer to the traditional heroin, we started to see things like Xylazine be in addition to that drug supply. What Xylazine does is while you have this initial intoxication from the fentanyl, the Xylazine will make the intoxication last longer because you're having the sedating effects. Additionally, Xylazine can be pretty cheap. So if you're trying to buy it in illicit manufactured websites, what you can see is that for $6 to $20, you can get a kilo of Xylazine, which means that you can have a lot higher profit margin, and patients will still have an experience that has a longer duration of action and still have the intoxication from the illicit fentanyl. The problem with this is that, as we've seen with these waves, is that you have the significant morbidity and mortality associated with them. This information here comes from a 2023 MMWR report, really highlighting the rising detection of Xylazine in illicitly manufactured fentanyl-related deaths. This report suggests that both increased testing and a true rise in Xylazine presence have contributed to this trend. However, inconsistent testing likely means that the detection of Xylazine is still underestimated. In April 2023, the White House Office of National Drug Control Policy really labeled fentanyl adulterated with xylazine as an emerging threat. The key findings in this report were that from January 2019 to June 2022, the percentage of illicitly manufactured fentanyl-involved deaths with detected xylazine increased by 276%. Xylazine was found in less than 12% of illicitly manufactured fentanyl-involved deaths overall, but rates varied significantly by the jurisdiction, from none to 27.7%. The highest rates were seen in the Northeast. The determination of xylazine as a cause of death also varied by jurisdiction. And the demographic characteristics, drug co-involvement, and circumstances were largely similar in illicitly manufactured involved deaths, regardless of the xylazine detection. Additionally, data from Millennium Labs in 2023 indicated that nationally 16% of fentanyl-positive specimens contain xylazine, whereas 99% of xylazine-positive specimens contain fentanyl. The DEA national seizure data showed that about 30% of fentanyl powder contained xylazine in 2023, which was up from 25% in 2022. And furthermore, recent DEA estimates indicated that xylazine was present in 48 of 50 states as of November 2022. The emergence of xylazine in the United States follows a pattern very similar to fentanyl, starting in the Northeast white powder heroin market before spreading to the South and then spreading westward. This suggests xylazine's use as an adulterant will likely increase and become common in the illicit fentanyl supply. It may also become a drug of abuse on its own, similar to what you can see in Puerto Rico. Currently, a comprehensive count of xylazine-positive overdose deaths is not possible due to inconsistent testing and its exclusion from the CDC's national overdose statistics. This likely leads to an underestimating of xylazine's presence. Despite this, xylazine has been identified as a contributing factor in many fatal overdoses, often alongside fentanyl, and sometimes as the sole cause of death. DEA reports indicate all U.S. Census regions have seen a significant increase in the xylazine-positive fatal overdoses from 2020 to 2021, with as high as totals in the Northeast. This reflects probably both expanded testing and rising use, with xylazine first appearing sporadically in the Northeast in 2006 and then increasing steadily since the 2010s. This right here is an example of things that are kind of published online where there's a lot of sensationalization associated with this. So when you see this and you see that the West Coast has had a 750% increase from 2020 to 2021, it's an extremely concerning trend. And while I don't want to detract from this trend, I do want to take a second to just kind of show you guys the numbers that are associated with this. So these maps right here are all taken from the USDEA information about xylazine-associated fentanyl overdoses, or xylazine-associated positive overdoses. So these are the exact same numbers, but what you are seeing here is that 750% increase. Really what that meant is that we saw 4 patients compared to 34 patients. And so it still isn't a concerning increase, but it's not quite as concerning as what you see when you look at the map that way. The other thing that I do want to point out with this is from this MMWR, there's a couple of characteristics that are pretty interesting. So while we know that there is a regional component to this, that we see this more in the Northeast than we see it in the West Coast area. The other thing that I want to point out right here is looking at the decedent data. So these are patients who died from a drug overdose that xylazine was associated with that. And the big thing with this is that while we see this with fentanyl, and this is expected, you can see that 98.7% of the ones at xylazine had fentanyl as well too. This is also seen with other drugs as well. So you're seeing this with benzodiazepines, with cocaine, with methamphetamines. And so the take home that I would have from this is just because somebody or your patient doesn't use opioids doesn't mean that they are not being exposed to this. Anytime that you don't have regulation, anytime that this is in a illicit market, there's always possible opportunities to have exposure to other adulterants or to get the wrong thing. And so just because you don't use opioids doesn't mean that this could not happen. Let's talk a little bit about the pharmacology of this. So as we mentioned before, xylazine was initially investigated because it was very structurally similar to clonidine. And you can see these right here. And clonidine is an antihypertensive that's been in use for decades. One of the big thing about this is that xylazine itself has more alpha-2 agonist features. And so what this means is that you're going to have a decreased amount of neurotransmitters that are going to get released. So when you have decreased amount of neurotransmitters, you're going to see a decreased response. And so from xylazine standpoint, this means a lot more sedation because you're not having those neurotransmitters to kind of keep you awake. From clonidine standpoint, what you can see with this is you can see more imidazoline features or imidazoline receptor effects. And so because of that, clonidine tends to have more bradycardia and hypotension. Now, when xylazine is in extreme doses, when you have really super therapeutic exposure, you can see that bradycardia and hypotension as well, but you don't usually see it to the extent that you do with clonidine overdose. A lot of the times what we see more is the sedation, and the sedation can be even more notable when you are using other agents that are CNS depressants. The other thing about xylazine as well is it's very lipophilic, which just means that it's going to pass into your brain really quickly, which is one of the reasons why you're looking for it is for that intoxication, is for it to get into the brain and have those fix. Published pharmacokinetic data on humans are mainly restricted to case studies and forensic testing, or we infer them from animal studies. While there's an extensive literature on the pharmacokinetics of xylazine in animals, applying these to humans can be challenging. In animals, xylazine is generally characterized by rapid absorption, distribution, metabolism, and elimination. When you administer it intravenously, effects typically begin within minutes and can last up to 4 hours. This reported rapid elimination half-life in animals, ranging from half an hour to 50 minutes, suggests that xylazine may have a short detection window in biological samples. However, xylazine also undergoes significant metabolism with over 20 identified metabolites whose pharmacologic properties and clinical effects in humans really remain unknown. Patients can swallow it by eating it, they can smoke it, they can snort it, they can inject it into the veins or into the muscles. And what you see with toxic exposure is you see a lot of the things that you see with an opioid overdose. You see this CNS depression. You can see respiratory depression, again, with really large doses or when you're using it with something else. In really large doses, you can also see bradycardia and hypotension that's a little bit more limited, which is kind of a standard exposure. But again, as you get to really, really high concentrations, you can kind of transition in the receptors you're hitting. And then also too, because you can hit some of the imidazoline receptors, you can see some hypoglycemia potentially as well too, just some changes in your blood sugar. One of the significant concerns related to xylazine exposure is the development of severe wounds and skin lesions. These wounds can range from localized irritation and necrosis to more extensive ulcerative lesions, potentially complicating the clinical management of the affected individuals. Chance to finish them. This right here is a study from Puerto Rico, where they were first starting to recognize that there was a difference in the amount of skin ulcers that you were seeing when patients were exposed to xylazine compared to when they were not. So this was published in 2008. It actually precedes that a little bit. But what you can really see right here is that in patients who had a positive xylazine exposure, they were more likely to be unhoused compared to the patients who did not have a xylazine exposure. But the big thing is that the prevalence of skin ulcers was significantly higher, even when you try to account for the living situation. And so this really started to become a big thing around that time where we recognized the significant changes that could occur from a dermatologic standpoint. Additionally, what they found in their survey is that people using xylazine really reported poor health outcomes more frequently than those who did not. And so there was seeming like there was other things about this drug property that was kind of changing how people were interacting with it. I will let you know, we're going to take a look at some pictures because you can't talk about xylazine without looking at those. If you're sensitive at all, if you have any concerns about these, feel free to look away. I will definitely let you know when we go back to the regular images to kind of bring you back in, but it can be a little graphic. So this is taken from a paper by McFadden that was published in 2024, and it's based out of a Philadelphia clinic. And one of the things that's really interesting about this is they've had a long time to really see the skin wound changes because this is one of the first places that we started to see xylazine exposure. And they really started to recognize that these wounds tend to look different than other IV drug use associated wounds. They really have this unique appearance to them and progression. They start as kind of this dark purple blisters with kind of irregular borders and intact skin. They commonly emerge around injection sites on the posterior forearms or the lower legs. And then these blisters start to coalesce, as you can see here in photo 2. And they harden into this kind of dry, adherent eschar. And then they can kind of open up into these deep ulcerative lesions that can be seen here. These example here on 4 is more of those deep, deep ulcers. The wound bed may initially contain islands of preserved tissue, although they're at risk of eventual erosion. And ulcerative depth can actually reach full thickness with exposed tendon and bone. All these wounds generally lack the classic signs of infection. The untreated eschar may foster superimposed infections characterized by peri-wound cellulitis and purulent drainage. And so here's just an example of how the same patient, how their wound changed over time. We're done with the pictures. What causes these? Well, there's a lot of ideas out there. Some of them are that it's a direct cytotoxic effect of the xylazine itself or some of the contaminants in the drug supply. Some people say, well, maybe it's an infectious component. You have an open wound, you're just kind of inviting bacteria. Some people think, well, maybe it's related to the drug properties itself. You know, if this drug is in the same class as something that is used for a blood pressure agent, maybe what you're seeing is kind of localized decreased blood perfusion there. Maybe it's because when you start to have these wounds, you start to lose some of those peripheral nerves, those really, really small peripheral nerves. And so as they have decreased sensation, people sometimes will inject into the wound bed more frequently. And so maybe it's just the trauma of repeat injections over time. One of the things that we know about this is there's a lot of sedation associated with it. So potentially it's related to being in a compressive situation, kind of laying on that arm for a long period of time. Maybe there's some sort of underlying vasculitis associated with it, where it's irritation of those small blood vessels. We've seen that with other contaminants. Maybe it's because when you have these wounds there, you're more likely to pick at them. All of these theories are out there, but none of them fully explain what's going on, because while patients who have IV drug use patterns tend to be more likely to have these when they use xylazine, we've still seen this with patients who've snorted, smoked, swallowed. Additionally, too, even if somebody is having an IV drug use as their route, one of the things that we'll see is we don't always see it directly at the wound where they're injecting. Sometimes we'll see it distally to that as well. And so it doesn't fit that it's IV drug use related either. It seems like there's kind of a couple different things going on that we just don't quite understand yet. This was an interesting study that was published a while ago where it really looked at the skin perfusion. And the big thing to kind of know from this is that your red triangle or your black triangles right here is kind of a control. And then your white triangles right here is with the associate with xylazine in it as well too. And you're looking at the oxygenation of the tissue here. And so what they did is they took mice and they injected them with one substance or the other, and then they saw the skin perfusion. And what you can see is that even though this isn't injected right to the skin, it's injected into a different area, you're still seeing a change in the skin perfusion. And so if your skin is not getting perfused well, it's not going to heal quite as well. And potentially too, there is like local changes there that maybe contribute to it. Again, doesn't explain everything, but does have some like thought-provoking component to this about maybe there's a part of this that's a component. The other thing that can be really hard with wound care is there's a lot of stigma associated with this. There is a lot of trauma with just having the wounds themselves. There may be a lot of concern about going to a hospital because you're maybe you're worried that your withdrawals are not going to be managed, or it's going to be really painful, or you've had a lot of traumatic experiences in the past. The labeling can be really hurtful. From a healthcare provider standpoint, this can be hard because you don't want somebody to overdose in a healthcare facility. You don't want somebody to get really sick. But as a patient, if somebody is searching through your things and taking out your personal belongings, that feels like it's a very violating. The other thing that can be really hard is sometimes too, if there's concerns about individuals having kind of drug sharing during a visit, sometimes their visitations are restricted as well, which means that you don't have a lot of social support. Additionally, too, this can be really hard because when we're trying to look at where do we discharge patients to after they've been in a hospital, sometimes if you're trying to get into a long-term nursing facility where they can help you with the wound care, they may struggle with managing an underlying substance use. Additionally, too, sometimes if you're trying to get into a detox bed or residential housing, there may be a lot of concerns about having that wound and having the expertise to manage it. And so sometimes patients are getting denied from these, and it can be really hard to figure out a place to go once they're out of the hospital. Additionally, places like specialty clinics can be very rigid with what their times are. And if you are somebody who's already struggling with sobriety, already struggling with trying to kind of get your life together and get to the things that you need to go to, being very limited with when you can go and how you get access to that can be really, really hard to get the follow-up you need. Lastly, shelter is such a huge portion to this. It can be really, really hard to take care of these wounds that need a lot of attention if you don't have appropriate housing, if you don't have access to clean water, if you don't have access to soap. And so just by virtue of having that unhoused, you are creating a huge barrier for patients to get access. So how do we really manage these? Well, there's a couple of recommendations, and I will say these are based again from a Philadelphia wound clinic. They've had a lot of exposure to this. There is not a lot of data-driven information out there about how to do this. There is not really randomized control trials, and so these are things that have worked for them. I will say these are not medical recommendations. I'm not sitting in front of you. I cannot see your wound, but these are things that they found that have worked really well for xylazine-associated wounds to kind of help them heal. One of the biggest steps with this is you really want to pre-medicate. Looking at doing a wound change or a dressing change can be really, really painful and cause a lot of anxiety. And so getting the patient into an appropriate mindset before we start can really help create a better experience for the patient and be, help with kind of the cooperation with this. When you're looking at removing the soil dressing, really try to minimize the pain. Use soaking it with water, saline to kind of help take this off. Sometimes letting the patient remove the dressing on their own, it's kind of like taking off your own Band-Aid. It really can be less painful than if somebody else is taking it off for you. When you're looking at cleansing it, this can start out with just saline, so general washes, soap and water. Can you move to chlorhexidine? One of the things that can be a big help is to just try the cleanser on a small amount of the wound just to kind of see how well patients are tolerating it. If there's a lot of non-viable tissue, they really recommend things like Bash or Dakin solution. The next part about this is debridement. So this is getting rid of the bad tissue. And there's a couple different options here. You have an enzymatic approach versus an autolytic approach. Now the enzymatic approach is really performed by a prescribed topical agent that chemically is going to liquefy the necrotic tissue with enzymes. While this can be very effective, it can also be extremely costly. It oftentimes requires a prescription, and it can be painful as well too. One of your other options is something like an autolytic approach, where what they really do is they really use your body's own enzymes and moisture beneath the dressing to kind of help liquefy that area, and you're kind of supporting it through the process. It's a very slow process. There's decreased pain associated with it, but you really have to be careful with the dressings during that time period because you can have a lot of saturation and increased drainage just because of that liquefaction that occurs with this. And so there's a couple agents that are listed here that can be used for it. The other thing that you can do as kind of a tip is you can actually put that on the dressing itself as opposed to putting it on the wound bed. Sometimes that can be a little bit more comfortable for the patient if you put it on the dressing and then put the dressing on as opposed to putting it directly on the wound itself. The other thing is you want to take care of the skin that's still there. And so you really want to protect that area. And so you can use A&D ointment. You can use kind of no sting skin prep to really kind of make sure that we preserve that area, that it doesn't continue to break down. Sometimes they'll use topical antibiotics. The systemic antibiotics sometimes won't penetrate deeper than the wound bed. And so to decrease the bioburden, sometimes we'll use those. And then you want to take a look at your primary dressing, and you really want to cut it to be the right shape because you don't want to have a lot of overlap with that peri wound because you don't want to have that continue to break down. Lastly, as we mentioned before, especially with these debridements, with other things going on, you're going to have a lot of drainage. So you really want to have a really absorbent dressing that's there. And this can be abdominal pads, this can be a lot of gauze, just making sure that we're kind of helping with that extreme amount of drainage that can occur. Last part about this is really securing it. And so you want to make sure that this is in a good spot and it's snug, so it's not going to be moving around and kind of irritating the tissue. But you also want to make sure that it's not too tight because that can also contribute to wound breakdown. And you really need to make sure that this is something that they're aware of to change so that it doesn't contribute to the wound breakdown as well. Finally, when we're looking at wound care, a lot of this is going to be aimed at patient instructions. So while we would like people to avoid injecting completely, we also recognize that that may not happen. And so really reminding them that you don't want to inject near that wound. You don't want to increase any more trauma. You don't want to have any decreased blood perfusion or whatever else is going on there. We don't want to make this worse. Really trying to minimize picking at the wounds, keeping it covered, wearing long sleeve shirts or pants to kind of keep those areas covered. And then really be cognizant of when things are getting worse, looking for signs of systemic illness. If all of a sudden they're feeling really unwell, if they're having fevers, if they're having a lot of fluctuance that seems like an abscess, if all of a sudden the wound is turning really, really red, or there's new pain, new numbness, or new spotted skin, those are really concerning features, and we want the patient to get seen. Additionally, too, if all of a sudden we're seeing bone or tendon, it's getting a lot deeper, they need to get seen if there's chunks of tissues falling out. And then last, but not least, oftentimes because of where the wounds location are, they can be in your forearms, they can be in your legs, they can be in other places too. But anytime that there's proximity to a joint, you really want to kind of keep an eye on that the joint's not getting really red, hot, painful, or difficult to move, because that can be a sign of septic arthritis, which can also be a very dangerous thing for to happen. Additionally, when we're talking about kind of this harm reduction, this is a very traumatic process. Just having a wound like this is really traumatic. And so really trying to find ways to kind of optimize the care and create a relationship that is going to ensure that the patient gets the care that they need. One of the things that's really easy is just ask the patient what wound care has worked well in the past. If that hasn't worked well, then kind of moving on to the next step. Really trying to engage the patient, letting them try and remove the dressing themselves. This can make it a little bit more comfortable and can kind of help them figure out how to manage it on their own when somebody's not there to do it. If anybody's ever farted in public, this can be incredibly embarrassing. This is kind of the same kind of thing. You have this really prominent odor that can occur with these. And so really trying to minimize the distress that's associated with this, whether or not this is air fresheners, therapy, having a window open, making sure that there's frequent trash changes, just really trying to normalize the process so there's not a lot of embarrassment related to that. Other things too is, especially if your patient has limited social resources, if they're unhoused, trying to be very cognizant of what you are having them send home with. And so if they're going home with oral antibiotics or other medications, is there a way that you can kind of have a lanyard attached container or something else so you can really kind of minimize theft and so they can continue to have access to what they need to. You also really want to be appropriate with your wound dressing changes. Well, sometimes as healthcare providers, we want somebody to take something or change something every 5 times a day. That can be really, really unrealistic. And so having really realistic expectations and then making sure that they have enough supplies to do the changes that you want them to as well too. If you only give them supplies for one day and they don't have access to money, how are they going to have another dressing change? And so really kind of thinking about that down the line of, this may be a little bit more costly up front, but potentially at the long run, if this means that they don't have an amputation, that can be a lot more beneficial for the patient, the hospital, wherever else they're going. Again, while we really encourage stopping exposure, that may or may not be realistic. And so really encouraging safe use, making sure that when they are using that they're not having, that there's somebody there that's watching for them, that they're not having continued compression to that area, that they're looking at clean needles or needle exchange, or at the minimum trying to supply them with alcohol wipes to try and minimize that. And then really collaborating with your local clinics, if they need to see an infectious disease doctor, if they need to see an internal medicine doctor, if they need to get wound care, trying to kind of time that so that it's all around the same time frame can really provide a benefit as opposed to having these like, I have to go see this person this day on this time, this person this day on this time. Can be really, really hard to coordinate that care. This is a post that was a Reddit survey. And what they did is they sent out this survey to anybody who was over 18 with the goal of really trying to figure out what was the exposure to xylazine like. And there's a couple things that I want to point out with this survey. And so one of the things right here is that when you see this, when we talk about what people are using, sometimes people are exposed to xylazine without intentionally going for it. But there is a small section of the population who actually wants those longer sedative effects. And there is a population specifically like in Puerto Rico, where we see that they want just the xylazine by itself. We don't see that as much in the United States, but just the more kind of a combination. There are some people who are purposely seeking that out. Another thing right here, when you're looking to see what are patients experiencing with it, well, a lot of this makes sense. Increased sedation. There is an increase in wound infections, as we saw before, increase in emergency medicine visits. But then if you look here, the drug use on a typical day. So we anticipate that there's going to be a lot of opioids that's kind of hand in hand with this, but you're also seeing other exposures as well too. And so there's other things that we need to address with this. Is there other things we need to be thinking about? There's also a little bit of kind of comments on the withdrawal spectrum, and we'll talk about that a little bit later. And then the last thing that I really want to point out to you is the methods of exposure. Classically, when you read about this, when you see news or coverage for this, we really talk about a lot of IV drug use association. But if you see here, a lot of times it's more intranasal or inhalational. And so just because your patient has xylazine exposure doesn't mean that there's an IV drug use component to it. And so being aware that there's other ways to be exposed to this as well. So moving from this, what about the patient who has a lot of toxicity acutely? What do we do with this? Well, as we've mentioned, you can see a lot of drowsiness, some pinpoint pupils, some cyanosis. You can see kind of a slow pulse or slower absolute breathing. And this sounds very similar to an opioid intoxication. Additionally, with these, there is a little bit of a difference between an intoxication and an overdose. Your overdose is kind of that extreme. You're moving from having a normal skin tone to having more of that cyanotic features. You're moving from having a normal breathing pattern to really not being effective with your breathing. Either you're breathing too slow or you're breathing too shallow, or you're having this gurgling pattern with this as well too. And so there's a little bit of a difference between those. And so what do you do when you see somebody who's got an overdose? Well, naloxone first. And then we want to look at kind of transitioning this person into that recovery position that's been mentioned before. And a lot of the benefit of this is making sure that they're not aspirating, making sure that they're able to breathe appropriately with this time period, making sure that we're getting help with this. And then also to being careful that we're not keeping them in this position for a long period of time. What is one of the side effects of naloxone? Breathing. And we like our patients breathing. I think that's a benefit. Now, I know that we've talked about naloxone a lot in the past, and one of the big things that's kind of a takeaway with this is that naloxone really works as an opioid antagonist. It's really going to reverse the effects of opioids. We've talked about it. Xylazine is not an opioid, so why is this even coming up? Well, it's coming up because for the most part, if you are seeing a xylazine component, there's usually an opioid on top of it. And so this is data that was presented by Lewis Nelson that looks at really the New Jersey State Police. And what you're really seeing is that while xylazine is listed here, it's usually listed in addition to an opioid. It's very rare that you're seeing xylazine only. And so because of that, you really want, xylazine does not have an antidote, but opioids do. There's things that we can do about it. And while some of this respiratory depression and sedation may be related to a synergistic effect, if we can minimize the opioid component of that, we can potentially change the outcome. Additionally, too, when we talk about things like naloxone resistant overdose, it doesn't mean, okay, we need to kind of walk away. It means that if they are not responding to naloxone, maybe it's because there's other substances on board like xylazine, or maybe there's something else. Maybe their blood sugar is too low. Maybe they're having a stroke or a heart attack. Either way, if they're not responding to this, they also need medical attention. And our goal with a lot of this is really to aim for improving the amount of ventilation that they're doing. You know, our goal is not to precipitate withdrawal, to not just kind of slam with naloxone over and over again, but our goal is to make sure that they're breathing effectively. And so we've got a couple different trainings, and you can see a lot of trainings online about how to give naloxone. I won't go into that in depth, but really know that our goal is to get them to breathe again, because that's important. And treat your opioid xylazine overdose with supportive care and then naloxone. Don't treat it based on what you think the exposure is, treat it based on what your clinical exam looks like. There's been a lot of consideration about like, how bad really is this? And this is a paper that looked at it with mice. It's kind of an interesting paper. And so what this is you're looking at mice exposures to red, which is xylazine, blue, which is fentanyl, and then purple, which is a combination of xylazine and fentanyl. And then right here on your left-hand side is lethality. And you can see at low doses, when you combine xylazine and fentanyl right here, you don't have a significant change in mortality. It's pretty similar across the board. But when you go to higher doses and you add this red 60, this blue 10, this purple right here is significantly greater than this. And so there's a lot of concern that there's an increased morbidity and mortality that's associated with the combination of xylazine and fentanyl. And there's a lot of concern that this potentially changes your patient's risk when they have both of those on board. but it's never that easy. This is a mouse data. So when we look at human data, from an experiential standpoint, there's things that go a little bit different. So this is a multi-center study that took place over 9 different emergency rooms. And what they did is they took anybody who had an opioid overdose, who survived the opioid overdose, and then they did a GCMS, a sampling of their blood to really determine what was in their exposure. And there was a difference between patients who had a xylazine exposure versus patients who had no xylazine. And again, all of these patients had opioids on them. It's just a matter of whether or not there was xylazine in addition to the opioids. The thing that was really interesting about this paper is when you looked at the number of patients who received CPR, you were less likely to receive CPR if there was xylazine on board compared to if xylazine was absent. Additionally, when you look at this coma, you were less likely to have a coma if xylazine was present compared to if the xylazine was absent. And there was a lot of question about this. This doesn't really make sense. Why is this going on? What does this really mean? And most of the things here are not statistically significant. The 2 that I'm pointing out are statistical significance and then near statistical significance. And while no cause for this finding can really be derived from the data, it's reasonable to speculate that either the presence of xylazine offers some protection, or potentially that xylazine is less toxic than the opioid. And so the greater the xylazine adulteration, the less opioid that's received by the patient or the user. And either way, maybe it's not quite as scary in combination, at least from an acute overdose standpoint, as some of the other ones. There really needs to be a lot more research to look at this because it doesn't quite fit with the bench data that we have. Well, is there anything that we can do about it? We talked a little about naloxone. Is there anything in the works for an antidote for xylazine? There are, but we probably won't see them, at least not anywhere soon. So there are some agents that are currently being used in animals to go ahead and reverse the effects of xylazine. So you have things like yohimbine, ativanazole, tolazolene, where these are either things that have not been tested in humans or have been tested in humans and have bad side effects, and so they've decided not to go through with it. Either way, without kind of knowing how this really affects the mortality, the pursuit of this reversal agent, it's not quite clear that we need it. And so a lot of the focus right now is just on managing the opioid component and then kind of the supportive care for this. Those other parts of it, maybe we'll see some research coming up. There may be some things in the works, but right now we're not seeing those being used in humans. Let's talk a little bit about testing. So as we mentioned before, we know that based on animal data and some human data too, that xylazine has a really short detection window. And we know that your urine is more likely to be positive than your blood at longer out. So there was a study that occurred in a cohort of patients about a year ago where they really looked to see when can you detect. And what they found is that about 30 hours was your limit of detection. So after that, you weren't really seeing it. Urine was kind of a better mechanism than anything else. But you also have to be able to test for that. And so right now, the way that we can test for it is things like GCMS. And so this is the novel psychoactive substance discovery, where it looks at emerging threats and they're trying to determine when those are positive. And so you can see that this is a GCMS sample where there's different patterns associated with xylazine compared to some of the other agents. Currently, we don't have a point of care immunoassay that's available. So things like where we can test for cocaine, opioids, ethanol in the emergency department, we don't have that for xylazine yet. And most hospitals really can't run this extensive testing that either requires liquid chromatography or mass spectrometry. There are places you can send it to, NMS, ARUP, Mayo, others, but it can take a while to come back and it may not be helpful in the immediate sense. And the other part about this is it can be really costly. You're sending a send-out test, and if it's not going to change the clinical outcome, who should pay for that? Should the patient really have to pay for that? And so there's a lot of controversy with this. They're used for epidemiological kind of monitoring. They can be helpful when you're looking at other considerations for mortality, but in most cases, we're not sending them off for those. There are some things that are available at home. So there are some test strips. These are made by Rapid Response. There's other ones available too. Depending on which website you go to, it's anywhere between $100 to $200 per box of 100. It's kind of like a pregnancy test. It's either positive or it's negative. So it's not going to give you the drug concentration. It's meant to be used on the drug product. It's not meant to be used on your own urine. So it's not being used to kind of check if somebody's had that exposure to them. there's a couple of things to just kind of be aware of. In Washington state, it's fine to have, but there are some concerns in other states that having this paraphernalia potentially is associated with some legal concerns. And so part of this depends on kind of where you are. Again, that's not as big of an issue in Washington state, but potentially in other places. The other thing with this too is that there's potential for false positives. And so lidocaine, levamisole, these are known contaminants. Diphenhydramine, also known as Benadryl. If you're taking Benadryl or if there's Benadryl in your substances, that can be false positive. If you're using stimulants, they don't recommend using this because there are a lot of false positives with methamphetamines or MDMA. And so you have to kind of take it with a grain of salt. The other thing to kind of mention real quick is the withdrawal syndrome. And so these kind of withdrawal features have a lot of overlap. And so oftentimes a classical clinical vignette with this is that you'll have somebody who comes in, gets admitted because they have a really, really bad wound. Then we start to see some opioid withdrawals and we manage those. And it seems like we get them on track with either methadone or buprenorphine. And then we start to see kind of these delayed, increasing anxiety, dysphoria, restlessness to the point where patients are looking at signing out AMA. And the hard part about this is there's a lot of overlap. And so we're not quite sure if this is an isolated withdrawal presentation, if this is related to the opioids. There's definitely times, and there's data that shows that you can have withdrawals from clonidine, you can have withdrawals from dexmedetomidine, which are in a similar class. And so it's possible that it's its own isolated withdrawal syndrome. It's possible that it's just kind of a protracted in the setting of the opioid. It's really hard to kind of mesh out in the setting of both the kind of the coexistence and codependence of fentanyl or fentanyl analogs and xylazine. What I would say is that if you're seeing these patients may need some adjuncts in addition to things like buprenorphine to kind of help manage, especially with that anxiety. There may be some hypertension that you have to look at treating as well too. This was a paper that was published by Durazio, who was really looking at like what other things should you consider in somebody who has a xylazine fentanyl withdrawal type presentation. And these are very similar to things that we have used in the past for opioids. The big thing to know is that make sure that we're still treating the opioid withdrawal as well too. And this also can make it really hard to kind of interpret your cows. And so making sure that we're not missing the opioid withdrawal within this presentation. Going to finish up with just a little bit of the legislation around this. So in 2023, the White House announced that this was an emerging threat. And as you can see, kind of right around that time period, we're seeing a significant increase in the number of legislative movements that were really there to kind of take a look at combating xylazine. This is a chart map from April 2024, that's when it was most updated, to really look to see, okay, what laws are out there right now to kind of address xylazine. And there's been a lot of different focuses on this. Some of these bills are have more than one thing that's associated with it. Some things are looking at scheduling it. So for instance, in Florida, it's scheduled as Schedule 1. Some places are looking at doing kind of a lower scheduling with this. Though nationally or federally, we don't have that. Some places are increasing penalties with it. Some places are kind of increasing your test access. Some places are kind of working in public access. So there's a lot of kind of different ways that people are approaching this. The other thing that we're starting to see too is there's other ways that we're looking at surveillance. So we talked a little bit about kind of Reddit posts and reaching out online to talk with people. We talked about some of the having sort of media kind of coverage of this as well too. But they're doing really unique ways to kind of monitor it. And so this is a surveillance that was done in Kentucky, where what they did is they actually tested their wastewater samples and to really see when xylazine was present in their wastewater, recognizing that that meant that there was more exposure than they were really seeing. And so things that are hatched, where in blue you're seeing positivity with the hatched, it's a wastewater treatment plant that's positive as well too. And then places in green are some of the testing areas. And so this was a really surprising feature and kind of gave them a pause about how else do we really need to look at this, knowing that there's other places like Philadelphia that have known to have high wastewater content as well too. What do you do with that? The other thing kind of with this about going back to the public awareness is how many of your patients really know that it's there. And so this is a recent study, 2024, it's in Rhode Island. So again, looking at an area of the United States that is more aware of xylazine compared to places like the West Coast. And what you're really seeing here is that only about 50% of patients were even aware of xylazine's existence. Very small proportion in this one who were pursuing xylazine at that time. decent percentage of them who thought they had had a xylazine exposure, whether or not they were told, whether or not they had their drug tested. There's a couple different ways that they report that they had that xylazine exposure. But one of the interesting things about this was that they were given the opportunity to go ahead and submit samples of their drugs to test for xylazine. And there is a disparity between how many patients thought that their drug was going to be xylazine positive versus how many were actually xylazine positive. And there was an increasing amount of xylazine positivity compared to what people thought it was going to be. There is a little light at the end of our tunnel. So for the first time, we're starting to see a plateau or potentially decrease in the amount of opioid deaths. And so this is looking at CDC data. And what you're seeing here is while we are significantly over 100,000 per year, you are seeing a decrease in your synthetic opioids from 2022 to 2023. And so that's some good news with this. The other thing, as I mentioned before, is that anytime we kind of do this conversation, there's always potential to sensationalize it. One of the things that I do want to point out is while I think xylazine is something that we should be aware of and something that we should be monitoring and preparing for how we want to manage this, the cases right now are extremely low in Washington state. And so this is data that was published by ADAI from the first quarter of 2024. And what you are really seeing with this is very, very small numbers of xylazine positive cases. And this was like 25. Of those 25, 24 of them had associated fentanyl as well too. And so while this is something that, especially with what we've seen in the rest of the country, I think that this is ways to prepare, how we manage potential withdrawals, how we manage kind of wound care, and what we do with kind of describing this and bringing awareness to the public. I also think that we also need to be aware that it's not crazy numbers here. So this does give us time to kind of get ready for it, but I think that we don't need to get super, super excited quite yet. The one thing that's a little bit hard about this data is, as we mentioned before, a lot of times these recreational drugs, the trends tend to be that it comes from the east, move to the south, and move to the west. These are percent of drug overdose changes over time. And as you can see, as a country, we're doing better. Our drug overdose reported deaths has decreased by 6.9% when you look at February 2023 to February 2024. But the thing that I would say that's a little bit of this is that Washington is still increasing. And so when you see this, we're better than we were before. We were not having quite as high spikes as we did when we compared November to November of 2022 to 2023. But we're still seeing an increase. And so there still is a lot of work for us to do as far as public awareness and overdose kind of awareness for everybody around it. I'm going to leave you with another quote that really just kind of talks again about the xylazine exposure from that same paper. And then after that, I'm open to any questions or comments or thoughts that anybody has.
I was pausing for a second just to finish reading that quote. That's a really excellent quote, Dr. Kaiser.
I'm safe to stop sharing.
Yeah, you're good. All right, so thank you for that. You covered so many different aspects of xylazine there. That was impressive. There is a question in the Q&A box, and folks, we've got a few minutes, so I encourage you to ask other questions as you have them. Have skin lesions from xylazine been observed in veterinary medicine that you're aware of?
For animals, I have to say, I would have to look it up. I don't know a lot about the animal data. Usually when we're giving it to animals, we're giving it under certain situations and we're not doing repetitive use. But I don't know. That'd be a good question. Yeah, I would have to get some more information on that one.
For sure. All right, thank you. I had jotted down just a couple questions on my own. And again, folks, ask them as you have them. Oh, hey, someone beat me to it. So we got another question here. How soon do the wounds start to show after use?
Depends. We can sometimes see these within a couple of days and then they can start to evolve. It's a little bit different than some of the other adulterants where it could be quite a bit faster than that. This one's not quite as fast. And sometimes too, it's hard because given everything that's going on, sometimes people aren't quite keeping track of what their skin looks like during this time period. And so there may be a delay in reporting or a delay to recognition of what's going on. And so that kind of contributes to it, but it's not immediate.
Gotcha. All right, another question that popped up in the Q&A box. How is xylazine primarily sourced on the street?
Primarily sourced, meaning, so there's a couple different ways I guess I could think about that. Let me know if I'm answering it the way that is helpful for you guys. So you can see this in pills, you can see this in powder, you can see this in, I've even seen it like liquids as well too. You can see this when I'm, I have a dark web Chinese supplier that I was able to find to kind of get access to it as well. There's been some questions about whether or not we're starting to see it kind of move in through Mexico as well. There's a couple different ways that it's kind of moving into the United States. There was kind of that transition as it kind of followed along from Puerto Rico to the United States as well too. So there's lots of different ways that you can do this. And again, there are some patients who are specifically seeking it out because they appreciate the intoxication that comes with this, but not everybody's like that. Sometimes this is just an accidental exposure. And sometimes too, this is an adulterant where there's not significant amounts, it's just trace, but it still is showing up positive when they're doing biologic samples or when they're testing drugs.
Gotcha. All right. So questions are flooding in now. So next one is there any information about how xylazine impacts pregnant people?
Substance use in pregnancy is always really, really hard. And this is always a very, very vulnerable population. And it's even more difficult because you are managing both aspects of this. Anytime that something puts mom at harm, it puts baby at harm. And so any times that we're seeing mom with a lot of sedation, potentially she's not getting enough oxygen, baby's not getting enough oxygen. Though there's not a lot of specific data that I know that it's just isolated that population, there are definitely females that are using, when we first started to see this in Puerto Rico, there was initially a higher prevalence of females for a short period of time as well too. I know that we do have a session coming up regarding substance use in pregnancy. I think, Alex, do you remember when that one is?
Oh my goodness. I will find it as you finish answering this question. Let me dig that up.
Unfortunately,
and so
we aren't having that session
this
this year.
Thank you,
We'll
Megan.
see next
Thank you,
year.
Megan.
So that could be a really good one to kind of touch base and ask them as well too, just because there's so many different ways that it impacts once you introduce a fetus into the conversation.
Absolutely. Thank you. Okay, next question here. Despite the low numbers of confirmed overdoses of xylazine in Washington state, have we been seeing any of those skin wounds, those skin lesions?
We think that there may be some. It's hard because anytime that something like this happens, there's a lot of focus on it. So at the Poison Center, we've definitely been called about trying to figure out whether or not this is a xylazine associated wound or not. And then sometimes too, patients are using multiple different substances and we're not routinely testing for it, so we don't know. Possibly we're seeing those. I would say that we are not seeing them to the extent that we have seen in the Northeast, but there's definitely possible aspects of this in Washington state.
All right, so this next question is kind of a doozy, so bear with me here. First, there's a compliment. Great presentation, very thorough. In your perspective, what's the criteria we should use as public health agencies to determine an elevation of our overall xylazine response? They go on to further say, should it be clusters or overdoses or wounds, all of that or more? Right now, we're kind of sitting on surveillance and telling community providers to hold off on sounding the alarm.
And this is always so hard because as soon as we start to kind of push this, there's a lot of fear that's associated with this as well too. And it's always really hard to kind of find that line of when do you start to bring awareness to it. I think what we can start to do is we can start to bring it in slowly to kind of get people ready to really talk about the fact that, you're using fentanyl, just be aware there's other things that could be in fentanyl. And let's talk about how you can use fentanyl safely. Or, hey, this is kind of trying to kind of tie in little bits of information, But I agree that we really want to be careful about sensationalizing it. When you look at some of these numbers, when you look at some of this media report, when you see something like 750% increase, that's a very, very scary percentage. And you don't want to get people really overwhelmed and not being able to process it appropriately, or not taking care of the other things that we need to take care of. But you also don't want to be like fentanyl, where we knew it was coming and we weren't as prepared as we could have been. And so I think it's just this slow dispersion where we slowly start to incorporate features over time. It's a little bit less of a fear factor with that, doing it that way and incorporating things that we already know, right? Like when you do your naloxone training, really focusing on treating the patient, not treating the exposure. And so that can be a little bit of a segue that you can use to talk about it. When you start to talk about how to do safe use, you can kind of incorporate some things of it in there. And so that would be the way that I would kind of approach it. I would say that if at any point we start to see more clusters, or we start to see a higher percentage of those, I think we'll have to ramp up our response. But I think right now we can start to kind of get our population ready, because if it's not xylazine, it'll be something else. And so we really want to try to find a way to make sure that we try to provide as much support and protection as we can.
I really love how you just said that, treating the patient and not the exposure. I think that was very powerful. All right, so I'm going to ask you one more question. Do you have any action items you would like anyone watching this right now to take?
I mean, my one action item is always the dream, is that please watch a video, figure out how to do naloxone, get naloxone available to you, because that's something that you can do that can save lives. And if you have a doubt, use it. It's not going to hurt somebody to give them naloxone. And so that'd be the one action item if I can request of anything. The other thing is the Poison Center is free, confidential. We're open 24/7. You know, we are here to help people. And so if you have any concerns, you are always welcome to call us. If there's somebody who is overdosing and is sick, we want you to call 911 first. We want you to get them taken care of. But if you're trying to figure out what to do, or if you have questions, there's always a smiling face on the other side of the phone that is happy to answer those questions and help you through it. And so one of the best things that you can do to kind of protect yourself from all sorts of toxicological emergencies is put the phone number in your cell phone, especially if you have kids that are babysitting, you have something else, having that available to you will help save you from heartache later on.
Absolutely. We have the Poison Center the Poison Helpline, excuse me, posted in the chat box there. That's 1-800-222-1222. And I want to draw folks' attention once again to the survey. If you'd like a certificate of attendance, please go ahead and click that link that Megan went ahead and put in the chat box. And we'll be sure to get that certificate to you. Well, Dr. Kaiser, it is always a pleasure to hear you speak. Thank you so much for joining the series this year.
Absolutely. Thank you guys so much for the opportunity. And I appreciate all of you guys who sat through lots and lots of slides and bared with me. So thank you so much for your time.
Excellent. Thank you. Now, folks, I encourage you to tune into our next session going at 2 o'clock. It is titled Meth, the Forgotten Drug. So go ahead and find that link as you need. And we hope to see you then. Thanks, everybody. Take care.